Welcome to the IDEXX Continuing Education Series.
Hello and welcome to my talk today on the benefits of C-reactive protein and more generally the use of acute phase proteins in practice. My name is Philippa McLaren and I am a specialist clinical pathologist and also the pathology services manager at IDEXX based in Melbourne. Today I'm going to talk to you about the background of acute phase proteins, what they are and how we can use them in clinical practice. Acute phase proteins are produced by the liver. Some of them will increase and some decrease in response to inflammatory stimuli, such as fragments of bacteria or damaged tissue. The liver changes how it produces proteins in response to these inflammatory stimuli, and we can measure that to understand how the body is reacting to inflammation. Before the advent of research about acute phase proteins, we were limited in our approach to inflammation to what we could see and the small amounts of changes that we were able to measure on the routine minimum database. So clinically in inflammatory patients, we would expect to see pyrexia in many cases. We're used to seeing patients that are not quite right, perhaps inappetent, or showing behavioural changes that give you an indication that something is causing them pain. Of course, we're all familiar with the standard rubric for inflammation of heat, pain, redness, and loss of function. In the lab, we can measure inflammation through changes in the CBC. So we're used to seeing a neutrophilia when the inflammation has been reasonably long-standing. And on the blood smear exam, we look at toxic change, left shift, and we can also see anemia of chronic disease occurring over time. In a more acute situation, we might be able to spot a transient neutropenia, which occurs before the bone marrow has had a chance to respond to the inflammatory stimulus by upgrading the amount of neutrophils being produced. And when there has been a shift of the marrow storage pool of neutrophils into circulation and their consumption in that inflammatory process before that bone marrow starts producing more cells effectively. On the biochemistry profile, over time, we might see an increase in globulins as part of the acute phase protein response. But when we measure globulin, we're measuring the total protein minus the albumin. And so that includes all of the chronic phase proteins, which are the antibodies that we're used to experiencing and understanding as part of a chronic antigen response. We will also see a decrease in albumin. And albumin has a half-life of 8 days in the dog. And so that causes some delay in that change. It's also affected by other factors such as dehydration, production by the liver for other purposes. Scratch that. On the biochemistry profile, we might over time start to see a decrease in the serum albumin concentration. But albumin has a half-life of 8 days in the dog, and so that takes some time. It's also a less sensitive marker of inflammation because of the other factors that impact on albumin concentration, namely dehydration, losses from the gut or the kidney in enteric and renal disease, and altered absorption and dietary proteins. So it's an insensitive marker of chronic inflammatory changes. With time, we can see an increase in globulins, and the globulin measurement on the biochemistry profile is a calculation from the total amount of protein in the sample minus the albumin. And so that globulin measurement includes the acute phase proteins other than albumin, but it also includes all the chronic phase proteins, which are antibodies that occur in response to that antigenic stimulation with a specific lymphocyte response and antibody production. So the acute phase proteins, by contrast, that we measure in our specific acute phase protein testing include CRP in dogs and very commonly in humans, SAA, or serum amyloid A, for horses, and in many species, fibrinogen is a standard part of the profile, whether it be in small animals or in ruminants. These are the positive acute phase proteins that we can measure. There are many others that we don't measure so frequently. And albumin is one of the negative acute phase proteins, meaning it decreases in the acute phase response to inflammation. So what are the drawbacks of some of the other acute phase proteins? Fibrinogen is a molecule that is predominantly for the purpose of forming the blood clot. And so it changes when there is clotting. As soon as there is any vascular damage or any sort of hemorrhage, fibrinogen will decrease because of consumption in that process. It's also a significant proportion of the total protein. And so, like albumin and globulin, it will increase in dehydration. If the baseline was 4 grams a litre and the animal becomes dehydrated, it might increase just enough to measure above the reference range and be perceived as an increase in fibrinogen due to acute phase protein response and inflammation, when in fact it is just because of dehydration. C-reactive protein is the ideal molecule to measure inflammatory disease in dogs and in humans because it has a very small amount in health, and that change doesn't occur with dehydration. It's not a molecule that is going to increase significantly because of a decrease in the water content of the blood. It's a positive acute phase protein, and the purpose of it is to provide defense against microorganisms. It presents the structure of the bacteria for pore forming and to stimulate complement. As you can see from this slide, there are tens of thousands of literature references to CRP, predominantly in the human literature, and this has been well understood for many, many years and is part of the profile that you'll usually get if you go to the doctor and ask for a blood test or if they're concerned about your health in any way. In dogs, there are nearly 500 articles published on CRP, so you can see that it's becoming more frequently used. CRP is really useful in a critical care situation. It changes rapidly within hours. At the same time that you might start to see a transient neutropenia because of consumption of neutrophils, the CRP will already be increasing. This graph that I'm presenting shows the increase in CRP measurements from the baseline, which is a small number, less than 10, to rapidly increasing numbers as much as 30 units over a period of less than 1 day. So in the surgical situation, you can use CRP to assess how much tissue damage you've caused. And there are several articles in the literature reflecting on how much trauma is caused and consequently inflammation occurs with different surgical procedures. In our clinical situation, we use CRP to understand several questions. The first one I like to use is this an inflammatory condition at all? Many times from my position within the lab, I don't have the benefit of much in the way of clinical exam or clinical findings reported to me, but I can tell you whether your patient had a significant inflammatory process because the CRP in the blood will be increased. My scale of interpretation is very simple to see on a numeric basis because CRP rises so significantly. We're not dealing with small changes. So the reference range is less than 10 units, and anything less than about 30 units shows mild, ongoing or active inflammation. For a typical patient with a significant inflammatory disease, severe things such as immune-mediated hemolytic or polyarthritis, sepsis, or any sort of inflammatory condition of significance will often have a CRP of greater than 100 units. Some of the other ways in which we use CRP include to understand what is changing over time. Because the measurement and the magnitude of the increase in CRP is so varied, and that because it changes so rapidly over time in an upwards and downwards response when inflammation is controlled, you can use CRP to understand how bad the disease is currently, and is it getting better or worse? So, for example, when you are trying to deal with a patient that has a severe active inflammatory process, you might want to know, is my treatment being effective? At what point might I start to reduce or cease the treatment? Some of the chronic conditions that we deal with that can be very challenging often necessitate antibiosis, and we want to be responsible in our use of antibiotic therapy. We want to ensure that we're not giving therapy for too long, and equally that we're not stopping too soon before infection is controlled, because both of those can lead to possible resistance occurring in the bacterial population. We also can use CRP to understand whether inflammation is a part of a bigger disease process. So, for example, if you have a neoplastic disease that has been suspected or diagnosed, you might also have inflammation as part of that process, and you want to know if giving pain medication that has an inflammatory control is worthwhile, or maybe whether you might want to focus on pain medication that is not predominantly targeting inflammation, which is going to be more effective in this situation. So I've already discussed using CRP to see, is the condition inflammatory and is inflammation a significant part of the disease? Do I need antibiotics or not? And then finally, is my treatment working? So some of the examples that I would give for this, we have many situations where we just don't know what the situation is in terms of inflammatory or not inflammatory, infectious or not infectious. Sometimes we're dealing with these in an acute and emergency situation. For example, the dog that presents with acute pulmonary signs. We don't know initially whether that's related to something cardiac, something pulmonary, something perhaps pleural. And because we now have CRP available to us on the catalyst in the clinic, you can very rapidly find out if there's an inflammatory component. And that might lead you to be more suspicious of perhaps aspiration pneumonia rather than cardiac disease, or a pyothorax rather than a hydrothorax. You might also like to question it in the case of the patient that presents where the owner is convinced that something's wrong, but you can't find anything clinically. And I see this very frequently when biochemistry and hematology show absolutely nothing at all. Completely normal profile, but somehow the disease affects things that are not being tested in the routine biochemistry panel. Our chemistry panel covers the basic organs, but there are some that don't have any representation on those profiles. Things like the musculoskeletal system, unless there's acute and active muscle destruction, you won't have inflammation related to the spine, to the joints. If the biochemistry and hematology panels show you nothing of significance, you might still have very significant disease elsewhere in the body in an organ system that's not reflected well in the chemistry and hematology panels. Because we know that the leukogram isn't always sensitive and that the neutrophil count is a balance between consumption and production, over time there may be a completely normal neutrophil count and no obvious toxic change or left shift, and yet still significant inflammation present. Some of the organs that don't have a representation on the chemistry panel would include the pulmonary system, the musculoskeletal system, and the neurological system. Basal disease, for example, might not have any significant changes. CRP can be used to assess if there's inflammation somewhere. It can help you to understand if a dog presenting with respiratory signs relating to the chest has pneumonia with active inflammation, perhaps an aspiration, or is it cardiac disease, which is not expected to be significantly inflammatory. While there might be a slight increase in CRP with a chronic inflammatory biased cardiac condition, most of the time the magnitude would be very small in cardiac disease, and that use of the CRP would allow you to differentiate those processes. Is it a pyothorax, or is it simply increase in fluid due to osmotic conditions or congestive cardiac disease? And second example, when you want to see if the treatment is working, you might want to know, can I stop inflammatory control? And this might not necessarily just be antibiotics, but also non-steroidals or steroids. For example, when you're monitoring the progression of your IMPA patients, you don't want to stop too soon because there's still that background of antigenic response and host overactivity as part of the pathogenesis of the disease. You want to make sure that all the inflammatory response is damped down fully before you start considering weaning the patient from the steroids. You might not know if there is a little degree of inflammation, particularly in your more stoic patients who have stopped limping, or when the joints are uniformly affected and the animal is managing its normal day-to-day life. In another example, if you've recently done some rather challenging surgery and you're concerned that your patient might be suffering from dysmotility because of an enterectomy, or worried that perhaps it's gone further and you have a sepsis to deal with, or peritonitis, you can use the magnitude of the CRP to point you in one direction or the other. When you're looking to cease antibiotics, it can be very valuable to see how that patient is responding, particularly for those chronic cases when you don't know or you can't easily access the tissue directly to see if the inflammation has gone with techniques such as an FNA or a biopsy. So the limitations of CRP. CRP is not going to help you localize the lesion. It's not going to give you a specific cause. And it's not always going to detect the very low grade or the very mild and chronic inflammatory conditions that aren't stimulating a significant amount of tissue damage. And rather than reflected in the literature, it's been my clinical impression that with some conditions that just affect mucosal surfaces, for example, a UTI that doesn't have a lot of damage occurring within the wall of the bladder and isn't associated with pyelonephritis, sometimes they don't seem to have the same increase in CRP that you might expect with something that is not exfoliating inflammatory cells from the surface. A rare case of diarrhea, for example, where any inflammatory exudate is lost in the gut content and to the outside world, might not have a systemic inflammatory stimulus returning to the liver. So it's not the absolute be-all and end-all, but it is very, very much more sensitive than the current routine minimum database, and sometimes more sensitive than your clinical exam, because not every dog will show fever, and not every dog will exhibit pain or be able to show specific features that will lead you to that inflammatory focus. I find CRP a really valuable part of my diagnostic workup, and I'm really glad to have it available both in the lab and in the Atlas in-house to allow you to access it really quickly. I think it's a very cost-effective way of using inflammatory markers to understand the processes in patients, and I hope that over time you'll start to see the benefits of this particular marker added both to the older patient minimum database as a screening test for background of inflammation, and more acutely in managing your critical patients and your post-op patients and those that you just don't know where to go to find the diagnosis. Thank you for listening. If you have any questions, feel free to bring them to any member of the pathologist team